Hi, this is Piyush Bhargava, and I have several interesting cases to share with you. Our first case is a 55-year-old female who presented with fluctuating hypertension and elevated urine metanephrines. We did a MR of the abdomen with and without IV contrast. Here we are looking at the coronal T2 weighted image showing a tumor arising from the right adrenal, showing T2 heterogeneous hyperintensity. We see the same thing here on the axial fat saturated T2 weighted image. The mass shows contrast enhancement seen here on arterial, portal venous, and delayed images. The mass does not have any internal fat because there is no signal drop on out of phase images, but it does show restricted diffusion with high signal on DWI and low signal on ADC. These findings are suggestive of a pheochromocytoma. Patient underwent a gallium-68 dotatate PET-CT, and here's the rotating image showing physiologic distribution of the tracer in the pituitary, salivary glands, liver, spleen, excretion from the kidneys into the urinary bladder, and intense uptake in the right adrenal mass seen here on the fused PET-CT image. These findings confirm pheochromocytoma and that there is no evidence of metastatic disease and that this patient can undergo a curative resection. Here is a companion case. We are looking at a left adrenal pheochromocytoma in this patient, seen here on the anterior and posterior whole body images using I-123 MIBG. So what do we want to remember regarding pheochromocytomas? These are adrenal medullary tumors associated with multiple endocrine neoplasia, neurofibromatosis type 1, von Hippel-Lindau disease, Sturge-Weber syndrome, and tuberous sclerosis. They have this 10% rule where 10% are bilateral, malignant, extraadrenal, seen in children, associated with syndromes, and are non-functioning. Typically, patients have elevated plasma catecholamines and urine metanephrines on CT. These are seen as heterogeneous, enhancing solid masses with slow washout, with imaging findings that overlap with benign adenomas. And when there is local invasion or metastatic disease, that suggests a malignant pheochromocytoma. On MR, these are T2 hyperintense, show contrast enhancement, and may show internal necrosis and hemorrhage. In terms of nuclear medicine studies, we now have gallium-68 dotatate PET-CT to evaluate these tumors. Earlier, we would use I-123 MIBG or indium-111 octreotide or even F18-FDG. Our second case is this 35-year-old female who presented with rectal bleeding, and a polyp was biopsied at colonoscopy and it showed a neuroendocrine tumor. This is their MR of the pelvis with and without contrast. Here on the coronal T2 weighted image, we see this tumor, which is seen as a isointense nodule arising from the anterior wall of the rectum. It is also seen right here on the coronal image without any extension outside the muscularis. It shows contrast enhancement, restricted diffusion, incidentally seen bilaterally enlarged kidneys with ovaries with peripheral small follicles, suggesting polycystic ovarian syndrome. This patient, since the initial tumor was of neuroendocrine origin, underwent a gallium-68 dotatate PET-CT. This is the whole body image showing focal intense uptake in the rectal tumor, seen here on the fused sagittal image corresponding to the sagittal image from the MRI. So the diagnosis here is rectal carcinoid. There is no extension beyond the muscularis as we saw on the MR, and there is no evidence of metastatic disease. So this patient can also undergo a curative resection under colonoscopy and can be followed up using gallium-68 dotatate PET-CT. Here is the companion case. This is a metastatic rectal carcinoid. You can see mural thickening here on the fused SPECT-CT image, and we have anterior and posterior whole body images using indium-111 octreotide. They have metastatic nodule in the presacral region, a bone met, and also a focus in the liver consistent with metastatic disease. So what do we want to know about these tumors? So these are neuroendocrine tumors that arise from Ipurd cells, which stands for amine precursor uptake and decarboxylation. Terminal ileum is the most common site for GI carcinoids, followed by the rectum. And the rectal carcinoids are frequently incidentally seen, or patients may present with pain and bleeding. The tumor markers that we follow, since these are neuroendocrine in origin, are chromogranin A and 5-HIAA. Carcinoid syndrome indicates liver mets. This is when the patients present with diarrhea, flushing, right heart failure, and bronchospasm. These are typically slow-growing tumors with good prognosis, and surgical resection is the treatment. On MR, these are T2 hyperintense. They enhance and show restricted diffusion. And for nuclear medicine, we use gallium-68 dotatate PET-CT now, and earlier we used to use indium-111 octreotide, I-123 MIBG, or F18FDG. Thank you for watching.